Welcome to this session where we're going closer down to the field after Alain's wonderful macro level tour of the ecosystem. We'll be hearing evidence from the ground. In a short while, we'll be hearing evidence from studies that have used mobile phone interventions to encourage behavior change. But firstly, though, we're going to hear from the perspective of a government mHealth implementer. I'm delighted that we've got Humphreys Nsona here from Malawi's Ministry of Health, where he's the program manager for the integrated management of childhood illnesses. And Humphreys has overseen the implementation of 2 mHealth applications, which he's going to tell us more about and answer the question whether these are the long-awaited solutions for effective and quality programs in resource-limited settings.
Thank you so much. Mine is basically, I think, a share of what, as Minister of Health in Malawi, has been able to work with the introduction of mHealth interventions in terms of adding on to an existing intervention that the Ministry of Health has been implementing. I assume majority of us geographically know where we are, where we have an under 5 mortality rate of 71, as well as total fertility rate of 5.7, with maternal mortality which is basically higher as 460. Our healthcare system in Malawi basically is one that above the Secretary for Health, we have tertiary hospitals, district hospitals, as well as community hospitals. And below that, we have what we call health facilities, and these are basically health centers. And at lower level, in the villages, we have what we call village clinics. The Ministry of Health has been implementing community case management from 2008 with the aim of improving child care services, especially in the management of malaria, pneumonia, and diarrhea amongst under 5 children in various communities in the country. And this intervention contained in the essential health care package of the health sector strategic plan in the Ministry of Health has been one of the key interventions that was aimed at and aims at improving quality of care provision, especially for sick children where we have limited health facilities, such that the presence of village clinics and indeed community case management for community health workers in communities in the country, helps under 5 children who are sick from the 3 conditions to seek care so that we avoid progression to severe illness. So using community case management with the coming in of innovations, one of the critical things that at inception in 2008 we did not have was issues to do with supply chain. And the supply chain got introduced in 2010 basically to ensure that commodities are also provided in a system approach, structured way, in line with what MOH intends to do to ensure availability of products. So, besides the supply chain innovation that we have had, we also worked and indeed introduced, my colleague from Tanzania yesterday introduced an intervention on behalf of Malawi, which is of course being supported by D3 on the case management mobile application. This, as Minister of Health, we have been working together with partner D3 because they introduced this intervention with the Minister of Health, and we were in a pilot phase on trying to learn how could this fit in an existing community case management implementation that was already in place in the country. And what basically the case management mobile application does is, mobile phones, these are Android, the cheap Android phones are uploaded with the assessment algorithms that are developed by WHO, adapted for country-specific, case management protocols to enable a community health worker provide and indeed conduct assessment of a sick child in various communities in the country. This has been one of the key elements because using the algorithms, we have allowed to ensure that community case, rather CHWs, who are basically trained for 6 days, use this, to rationally make decisions in identifying and also classifying an illness in a child. With that, basically, the innovation allows, the CHW to log in on their ordinary mobile phone, get patient particulars, and indeed registers the child, as well as in the process, conducts an assessment using view of the mobile phone, where the algorithms are, uploaded, and the CHWs are basically taken up in a stepwise approach to assess how they're supposed to conduct care, and thereby also coming up with a decision whether a child has fever and then it requires a test, and indeed if they have diarrhea, there's dehydration, and then they are given options for providing appropriate treatment. I spoke about the supply chain. The supply chain initiative and indeed innovation that got introduced is one that is automated, includes the transmission of logistic information via ordinary CHW phones to enable the CHW, check and indeed asks for availability of commodities. What normally happens with the supply chain initiative is basically, we have a cloud server, and then information is relayed and coordinated, whereby a CHW sends an SMS on stock on hand every month, and this information, is indeed reaches health centers and indeed the coordinating units at district hospital settings. And what the innovation does basically is it streamlines, resupply processes, whereby HSAs and indeed the CHWs in our context, are able, to get resupplies, and indeed issues of drug stockouts are minimized. What we have so far benefited at the 3 levels where supply chain, especially for community case management, has been initiated and adapted with the Ministry of Health. We have seen that the reporting of stock on hand, issues of stockouts, and indeed notifications and product receipts of transfers of stock commodities are done timely at the level of the community. Likewise, there is a better coordination on supply chain issues of community case management for facility level settings, similarly for the district level settings, where monitoring of product availability is done, and then resupply actions are determined based on the reports that are sent from community level. There are several benefits towards this. As I said earlier on, in 2008, when we introduced community case management, we did not have a structured way of ensuring monitoring of commodities for community case management at that level. But when we introduced this supply chain, which we normally call SISTOC, there was improved communication, timeliness in terms of reporting, and indeed resupplies. And also there was visibility of commodities, especially for CHWs at community level. While for the case management application, which we are getting support from D3, and also it's in the process of being taken up by government. There have been improved adherence to protocol, as well as issues of minimal error in relation to making proper judgment, and in turn issues of quality of care are influenced. We have, however, challenges that on supply chain, issues of connectivity, being a low resource country, settings where electricity and indeed rural communities do not have access to basic amenities, issues of electricity, and indeed where people could not charge their mobile phones becomes one of the issues. And the cost of the intervention is one of the critical elements that the government is trying to mobilize to make sure that this, looking at long-term solutions, we are supposed to be working with the telco companies in the country, because this is not a standalone innovation with the ministry. It needs connectivity with the mobile companies that we have. We have had, because of the outputs that are very positive in providing supply chain, especially for community case management, we have seen so many community health programs, willing to be part and parcel of this. And there has been room on how best we can accommodate, the other communities for proper monitoring, especially those that are being handled by CHWs. What the system does not do at the moment is basically, we only have provision for the logistics data, and then the statistics data we are using the other routine paper-based reporting methods, and there are ways how best this could be done, because the issues of integration that I think have been discussed here becomes paramount to make sure that the same individual who is generating data on logistics, I think, should be able to compile the same data using a similar application for the statistics data. And similarly, issues of mobile phones, besides motivating, there are issues to do with capacity, the orientation, and indeed some of them, they get lost, and where they get charged normally, people in the villages, they use the ordinary car batteries to charge, mobile phones, and these most of the times have affected, lifespan of the Android phones. We, however, appreciate the introduction of the two interventions, which have basically been recommended and taken up by Ministry of Health on the supply chain, and indeed on the case management mobile application, especially for community case management, where structures and proper structures are not available to initiate proper follow-ups and indeed monitoring of the intervention. But the introduction of these have brought in an aspect where we can track and indeed monitor what is happening at community level, such that leadership within the Ministry of Health has ably led the process and indeed adopted this, so that we champion and indeed have this as part and parcel of the MOH implementation framework for the health sector strategic plan. We value the partnership that exists with various partners, as well as the success of this program. Basically, it's dependent not just from the national level, but the district colleagues and indeed the CHWs that are essential, and their involvement has been critical to make the programs a success. We want to reach to scale, especially for the case management application, and also looking at possible ways of integrating, where possible, innovations that have to be packaged at various levels of our service delivery, especially at community level, and building on to the monitoring and the evaluation frameworks that the government has in the moment. issues of capacity building still remains important, because this is the only approach where we should be seen from partner to health headquarters, and indeed transferring of knowledge and skills to the users of the information. Basically, we have the commitment, and we look forward to making sure that we do not fail in ensuring the success of some of these interventions, and indeed for those that will come later on. We want to acknowledge support and partnerships that has existed in the country in relation to what we have so far managed to work together on and initiate a successful implementation. One of the issues that is outside, I think, my talk here has been the ability of also the mobile phones. Malawi, 3 weeks ago, has been hit with floods. I think some of us must have noticed this. The BBC was also sharing, I think, what happened there, and mobile phones, and what basically was happening in each and every area that was affected by floods was instantly reported, and within the resources that the country managed to, we were able to mobilize, I think, the few resources that are there, which of course we still need more resources as a country, because it has been overwhelming for us to contain the situation, because we had rains for over 7 days non-stop, and that affected most of the areas in the country. So it's another challenge that has come, and obviously it would affect how we initiate some of the interventions. The process now is trying to get restoration processes, and we lost more than 200 lives with these floods. Thank you so much.
Thank you very much, Mr. Nsona, for that extremely interesting talk from the ground. I'm guessing from your conclusion slide that benefits outweigh those challenges. But you did describe some of the considerable challenges in implementing mHealth solutions on the ground. And thank you for drawing our attention to the flooding situation in Malawi, but also other uses of mobile telephony for, I guess, humanitarian response would be how BBC Media Action would term it. I'm going to open the floor up to discussion. So if anyone has a question, please do raise your hand. And there's a gentleman there.
Yeah, thank you very much for the presentation. It was excellent and very refreshing to hear both the positive and the challenges as well, and important that we get that. So maybe focusing on thinking about, this is particularly focused on your talk, but it's a general question. So you mentioned your stock control application. There's a challenge if you've got areas where limited electricity supply, limited mobile phone connectivity. So what do you do? Does that mean you can't move that application forward until the infrastructure is in place? Or are you going to try and come up with some hybrids so that areas without the infrastructure rely on your older, presumably paper-based systems, but this can be implemented? Or is that just infeasible?
Yeah, it is an operational challenge that sometimes is beyond Ministry of Health, because these are issues that we get affected in terms of how best can we work together with other institutions of government and indeed parastatals. Unfortunately, I think we still lack that level of equal performance or demand-driven approaches towards making sure that whatever should be happening in sector A automatically, because it is useful for sector B, these things, they should be in line, and indeed making sure that service provision is of quality. There have been approaches, but these have not basically happened from national level to districts, but rather district focus, where you have specific challenges. The district health management teams have initiated, approaches to interact with either local communities and indeed the providers of that particular service in the district to look into it so that possibly they could resolve some of the issues. But it is, a challenge that normally sometimes and most of the times is beyond, MOH control.
Thanks for the good presentation. I want to echo the previous sentiment. My question is, again, with sort of relate to some of the point that Alan made, the fourth stage or fourth area of sort of integration and scale. So the supply chain component of this mHealth application will very much be helpful and straightforwardly applicable to the family planning commodities. They face the very same challenges. Commodity are usually not available, and whatever you are gaining here could be useful for them. But again, this sits into a different sort of unit, right, with the Ministry of Health. Same thing for the IMCI. I mean, all those breakthroughs could also be used to manage, pregnancy and delivery. So as we gear toward this full integration into the broader health systems, what do you see as the next steps or the challenges or the opportunities that we should seize to make that hopefully next level happen? Thanks.
The drivers for change are basically, exist at national level because coordination of the national programs, starts from with the Ministry of Health headquarters. What we have had is the pace at which we were to move together, in achieving, I think, incorporation and inclusion of the other products into the supply chain, especially for community case management. What we have had so far with the introduction of the supply chain at community level, when we were working with JSI, who then had funding from Bill and Melinda Gates, in a pilot understanding, we used the IMCI and its products as an entry point so that we draw lessons. And then after that, then we shared and disseminated, I think, the outcomes from that. From there, we wanted to work with, all programs that have community health interventions to have their products and be able to use the supply chain innovation that is existed at community level. The pace and the energy, has been dependent on, the strength of each and every program at ministry level. However, the drive is still there, and because community case management, we only have, 4 commodities. That's antimalarials, zinc and ORS, antibiotics for pneumonia, as well as, the fourth one is, it's for diarrhea, pneumonia, and the fever. So, those are the 4 commodities that we normally focus on. And in my slide, I presented about 17 commodities. Some of them are HIV, products because of the HIV testing and counseling that also exists at community level. There are very few products on family planning, like condoms and a few others. There are others that, based on policy, as a country, we have not yet agreed on whether CHWs could be giving things like injectable, gentamicin for newborns and a few other things. So those are some of the, steps that we are still working towards. But the intention and the goal is indeed to reach to scale so that this package of interventions, especially on commodities for supply chain, exists, as a model with the community case management sites in the villages.
Yeah, I think we've got time for one more question. Anna.
So it's a question and a comment. Thank you for that wonderful presentation. We actually have had the privilege of working with JSI and the ministry and the evaluation of C-stock. And I think one of the most interesting parts of the C-stock implementation is that they've done much more than just mHealth, where this enhanced management approach has built new structures within the ministry, national product availability teams, district product availability teams, new cadres of workers who are given the capacity to analyze and respond to data. Could you perhaps speak to how that's been seen within the broader ministry as a systemic approach to strengthening the capacity of the workforce to use and respond to data?
Yeah, the coming in of the supply chain, especially on enhanced management approach within the Ministry of Health, did not just focus on introducing an innovation and let it go and expect things to be moving on their own. Rather, there was a realization on the need to form what we called, product availability teams. These are basically what we used to call previously during the primary healthcare days, the drug committees, for example. So you have the national level product availability team, and then we have also the district level product availability team, and also the health center level product availability team. These teams, provides monitoring and indeed responds to, issues of emergency orders, the supply, because the system usually, sends messages which are received by, different groups of individuals, either supervisors at health facility level and indeed supervisors at district level. And also the national level, is able to track and understand what is going on within the system at national level. Because we have a secretariat at the national level within the health technical support services in the ministry, which oversees the coordination and performance of each and every CHW, because all their contact information, including their mobile phones, are within the dashboard and can be accessed at any time. So that when we have missing information, lack of data, or indeed no responses that are either done from health center level and district level, then the product availability teams, which normally meets every month, sits down and look back on how best they could have done in some of the areas that needed to be responsive to make sure that products are indeed available at all times at service provision level of the CHW. In addition to that, the supply chain monitoring mechanism using the product availability team has allowed, CHWs to have only commodities that they would need to use at one particular time. We have not been able, using the system, to allow the system to overflood them with products that they don't need. And that is one of the strengths of making sure that besides having products available, they only have those that are required for utilization. Okay, thank you.
Thank you very much. That last point's an extremely interesting point, because I'm assuming it cuts down on wastage as well,
That's it.
and helps issues of drugs going out of date.